and thank you very much for giving us your time to come to this webinar. Welcome. This is our North East London clinical webinar focusing on GPCPCS patient access. So what's GPCPCS? That's General Practice Community Pharmacy Consultation Service, which I personally as a GP have had absolutely brilliant results with. This webinar is hosted in conjunction with NEL CCG, our LPC colleagues, and NEL North East London Training Hubs. So thank you everybody for just remaining muted. That's really kind of you. And if you could kindly keep yourselves on mute, and if you don't mind just turning your videos off, that'll give you some privacy and also just help with the bandwidth as well. We want this to be as interactive and useful for you as possible, so please feel free to put questions and comments in the chat box, and we'll certainly be taking those through and try our best to answer all the questions. This session is recorded, if that's all right, and we will be sharing this session with you via a private YouTube link, hopefully within the next couple of days, if not the next day. So if that's all right, I'd love to introduce someone who many of you will actually know through her various career, long career through TV and lots, and a very lovely special friend of mine who is also, of course, clinical director and creator of Patient Access. So over to you. Thank you, Dr. Sarah Jarvis.
Thank you very much indeed for your very kind introduction, Fazana. I wish I had created Patient Access. I did create the clinical content for the CPCS triage, though. I think Idris would be jumping up and down because CPCS is I think really was his brainchild. So if I give you just a little bit of background, I'm sure you will all remember that about 3 years ago, NHS 111 developed a new system whereby patients who phoned NHS 111 could be referred in for a consultation with a pharmacy, and that was the beginning of CPCS. What then happened was that it was rolled out to general practices in a few small pilot areas, and about 2 and a bit years ago, BC, before COVID, we looked at this and Idris came to me and said we could do better than this. And the rationale was that I'm sure all of you will have seen the single sheet of A4 paper which has the traffic lights on it, the red and green traffic lights of conditions which are suitable for patients to be referred to. And the feedback that we were getting, I spoke to some of the receptionists at my practice, and their feedback was, well, the problem I've got is that, you know, if I say to a patient, I'm going to refer you to see a pharmacist, they are not impressed. They say, oh, well, you know, you're not clinically trained. Why are you asking me clinical questions? And why, as a pharmacist, you know, I want to see a doctor. I don't want to see a pharmacist. So we set out to do several things. The first thing we aimed to do was to help receptionists to understand, to work with their patients so that they could understand that the pharmacist is an absolutely key member of the primary care team. And this, I think, is still possibly one of the most important things that we're going to aim to do. We really want to help embed pharmacists, community pharmacists, who play an invaluable role as key members of the primary healthcare team and as the experts in minor conditions. The second thing we wanted to do was to empower receptionists. So the rationale was that we would develop a clinical triage tool which was as simple as it could possibly be, while maintaining clinical safety, obviously. And we are now in well over 2,000 practices in significantly over 72 CCGs. I think Idris can give you the latest figures. And we have had several comments back that along the lines of the great thing about the triage is that it's for a receptionist, you have got a GP sitting on your shoulder. So effectively, we have produced wording which allows the receptionist to provide really positive psychological wording based on psychological principles of empowering the patient, of making it in their interest, so it's in the patient's interest to want to be referred. We've also got all the clinical tools that the receptionist will need to be able to say, I know I'm not a receptionist, but I'm asking you exactly the same questions that you would be asked by the GP. And only if you come out at the other end and it says that this is suitable for you, will we refer you? And if that is the case, then that is exactly what the GP would also have been doing. At the same time, Idris, who is our tech guru, wanted to create an end-to-end system. And the great thing about this end-to-end system is that it can be accessed from within EMIS. It is there on all your toolbars. You can't see it yet. It's hidden, but once it's activated, it becomes evident on the toolbar. It can be reached from various places when you within EMIS, and it will take you straight in. And really importantly, there is no dual login. It carries all your credentials across. We're going to show you a test system, so there are no IT and no GDPR confidentiality issues. All the patients are test patients. But all the information of the GP, all the information of the patient is mapped across, so you don't need to enter anything again, and it gives you the opportunity. And on average, our receptionists say it takes about 2.5 to 3 minutes to complete, which, as several of them have pointed out, is probably less time than it takes to try and find an appointment for a patient when you haven't got any appointments. And you can then not only enter all the data, you can find a local pharmacy at the click of it. The patient can choose what pharmacy they want to go to. At the click of a button, you can send a referral. We have a new system which is in development, which should be ready within the next month, and that will also do several new things. Firstly, it will send details back to the patient record. So the details of the questions that the patient has answered are all going to be in the patient record, and there's going to be a login. Sorry, a notification rather, that this is a referral to CPCS. Now, of course, as of April, when funding follows the patient for referrals to CPCS, that will be very important because you'll be able to track how many patients you've referred to CPCS, and you'll be able to claim on that basis. But the information will go into the patient record. And in the new version, the information will also go to the patient with a different version of a summary telling them what they've answered, but also giving them details of their consultation. And then in addition, the form will go straight through to the pharmacist. At the moment, the details that the patient has been referred go through to the pharmacist, and different CCGs have different systems in place. The standard is that the patient contacts is required to contact the pharmacy, and according to the advanced service specification for CPCS for pharmacies, if the pharmacist has not heard within 12 working hours from the patient, they're required to attempt to make contact with the patient. We did a training session yesterday with a CCG where they have a system in place whereby they have made arrangements and agreements with local pharmacies that the pharmacist will contact the patient. So the receptionist can just say to the patient, so you've all been referred, the pharmacist will be getting in touch with you within the next 1 working day, and will arrange an appointment for you the same day. So there are lots of positive elements. Once the form gets to the pharmacy, we have Kevin Noble, who is going to take us through things from the pharmacy end, and the pharmacist can carry out the consultation, can claim in farm outcomes for that CPCS service. So it's all integrated right the way through, and can send details of the consultation back to the GP. So everything is integrated end to end. So I'm going to invite our tech guru, to whom I referred earlier, Idris, to come on and share his screen so that he can take you through all the bits of that I've missed, and then take us through the flow, and I can explain to you a little bit about the clinical system. Idris, I saw you there. There you are.
Thank you, Sarah. Obviously, there's been a big build-up, so hopefully I'll live up to the expectations that Sarah has set. Just to let you know, so in terms of myself, I'm Idris, and it's actually great that I'm actually in North East London because I actually live in Ilford, and I can see Balfour Road Surgery on this call, so I'm 2 doors away from Balfour Road Surgery. So know that they'll be knocking on my door and saying, how does this button work? So that's good to know. But just to let you know, in terms of what I'll do is I'll demonstrate the service to you guys from an EMIS web perspective. Then I'm going to hand over to Kevin, who will explain how the system works when the referral arrives in the CPCS perspective. I think it's important that from your perspective, I think the majority of the people on here represent the GP side, but I think it's important to understand how the end-to-end flow works. So you have confidence in the process itself, and there is safe netting involved in terms of making sure that the patient is treated and put first in the whole scenario. Just in terms of the demonstration itself, the data that you'll be seeing in the EMIS web is a test system, so you'll see data in there which is test data. So from a PII perspective, we should be totally okay to share the data, and if you want to take screen grabs from that perspective. So I'm going to share my screen now. So hopefully you can see EMIS web. Somebody can give me a thumbs up,
Yep.
thumbs down, or whatever. Cool,
All
great.
there.
Thank you very much. Like I said, this is a test system. The version of EMIS-Web we're looking at in here is 9.12. And this software that we're going to be talking about has been released from EMIS-Web 9.8 onwards. And I believe every single EMIS practice is already updated to 9.13. So I think we've actually enabled this capability across North East London already. So hopefully what we'll just be doing is demonstrating how the capability works. So when you click on the appointment book, what we introduced is a button called Patient Access Connect. And like I said, if any GP practice does not have this button enabled, then please work through your CCG or PCN point of contact, and they'll contact EMIS directly, and then we can make sure the activation takes place. The button itself should be on for you guys. So if I click on this button, Patient Access Connect, I should have mentioned actually before I do that this button is not only available in the appointment book, but it's also available in the consultation section as well. So this is if you wanted to refer the patient if they're in the middle of a consultation, you could do that as well if needs be.
If I could just point out, Idris, just one additional point to that. One of the things that many of our GPs do is that, for instance, if they get a form in through eConsult or online consult, and they look at it, and from their perspective, they've looked at it and clinically this is appropriate for the patient to be referred, then they can send a task through to the receptionist to contact the patient and ask them if they'd like a consultation. And that way, the receptionist can bypass the assess for referral system, so they can go straight in to the referral. And again, that will mean that the payment will be made, but importantly, it will allow you, because what you're going to see is that you can bypass that.
Okay, so thank you for that, Sarah. So just in terms of, I saw a question pop up in terms of patient access account. We're just using patient access because the team that developed this was the patient access team. The name of this service is actually going to change to local services, and this has no bearing whether you've got a patient access account or not. This is a completely independent of patient access from that perspective. Okay. So if I click on Patient Access Connect, then you get the, if you're not already in the patient context already, then you get the search box that pops up. So we'll click on here, my test user. And just the key things that we want to take away before I continue on with the demo is that it launches a web view on top of EMIS-Web already. One of the big things that we wanted to avoid was have another system that you need to log into when you integrate it into EMIS-Web. So in this situation, we use the same login that you have when you logged into EMIS-Web to authenticate you onto this portal as well, so you can avoid the double remembering another username and password to access another system. In addition to that, we also pull in the metadata from the patient record in the GP system as well. So the source of truth in terms of the data you're seeing in here, and we'll explain that a little bit more in a second, is all coming from the GP record itself. So having the data accurate in the GP record is obviously critical. Because this is a test system, you are seeing other services that this system can enable referrals into. So we won't talk about that per se, but obviously, if the key thing to take away from this screen's perspective is Saj has already kind of jumped the gun a bit. The reason you're seeing additional services within here is this is a test system. So this system can be extended to support other referrals as well. But the purposes of the demo, we're focusing on GP community pharmacy referral, and that has been pasted in the screen. All of you guys should be seeing that single button with a wide view with the buttons on there. Okay. So what you're seeing here are three call to actions: a create referral, an assessment for referral, and a referral for report. So as always, I'll start in the middle, which is assessment for referral. I'll click on that. And this is basically the triage capability that Sarah described earlier. So, but kind of it's like a GP on your shoulder where you can refer to guide a patient through a bunch of questions, and depending on the questions and how they answer that question, the patient is then pathwayed into the correct care pathway. So I'll run this demonstration. I'll let Sarah drive some of the questions as they're going along, and then hopefully you get a better understanding of how that works. So if I click on begin assessment, Sarah, do you want to drive or do you want me to drive?
I absolutely will. So Just to make one point here, we are just in the process of removing some questions in a couple of screens time which relate to COVID. We are in the difficult situation where the government have decided effectively to remove all regulations which relate to COVID. They've removed, of course, all the mandatory requirements for self-isolation and so on. And after discussion with several GPs, we made the decision, there was a consensus that we should remove the mandatory requirement not to proceed with the form if the patient had symptoms of COVID, and of course to remove the element which requires patients to self-isolate if they are not vaccinated, for instance. However, we will be adding wording at the bottom of this which makes the point that even though the regulations, the mandatory wearing of face coverings has been removed from the regulations, your practice or your pharmacy may require you for infection control to wear a face covering, and please do not attend the surgery or the pharmacy if you have some potential symptoms of COVID. So having got past that, I'll show you what's being removed in a couple of screens time, but just to take you to the top of the screen, the whole point about this wording, as I say, is that it's been very carefully developed to be positive in terms of encouraging the patient. So the wording is wording which I developed with another clinical colleague to provide a sort of cheat sheet for receptionists, and they liked it so much they asked us to add it to the front of the screen so they didn't have to have a copy on their reception desk in front of them. So the whole point about this is not about you can help save the NHS, you can help reduce the number of appointments your GP has to do. What it is saying is this is in your interest. So did you know we have a new service? It can get you the right help faster. Pharmacists are highly qualified. They've got all the same qualification, high levels of qualification. They're experts in this. They don't just dispense tablets. They're experts in minor illness. You can get an appointment quicker with them than you can get from our GP. And we will make the point that that this is something which is available for patients as part of an appointment service. We also make the point that we're going to ask some questions to make sure it's safe for you to be referred. And most patients, of course, these days are fairly used to submitting forms via online consult or e-consult, so they know that sometimes there is triage involved. Now, the National Advanced Service Specification for Pharmacists requires them not to provide the service to under 1-year-olds, so we have currently excluded under 1-year-olds. We're going to continue there. We then move on, and this is the standard NHS emergency wording. You can go through it very quickly with the patient. But, have you got any chest pain? Have you got any drooping of one side? Are you confused, or are you unconscious? Have you got severe difficulty in breathing? If you've got the patient in front of you, of course, you'll be able to go through this very, very quickly because you'll be able to see. But we just then tick on those. That's a requirement from NHS E&I. These are the standard questions that the patient would be asked if they went on to NHS 111. So the patient doesn't have any of those. And then we are going to go through the next screen, and this is the screen which is going. So again, one more screen which is going. It's going to be even quicker to complete the forms because we have a process of getting rid of them. So we then move on, and these are the options which are available. We've had a question come up about blood pressure. Blood pressure is not a minor illness, but we are actually we are going to include the possibility, for instance, on that first screen that you saw, whether there were several services, you could have a referral to the hypertension case finding service. So we can take any question you want, really. Let's go with, say, conjunctivitis or sticky eye. Actually, no, let's go with back pain because I did sticky eye yesterday. I'm bored of sticky eyes. Let's do that instead. Okay, so you just go down to the bottom, and these are the questions that we'd ask you to read out to the patient, and you can go through these pretty quickly. I'm going to just time myself now. So I'm going to ask you some questions. Can you stop me if the answer is yes to any of these? And when we get to the end, can you just confirm that you haven't got any of these? Have you had any significant trauma like a road traffic accident, a fall, or a serious head injury? Are you bleeding heavily because you've hurt yourself? Have you got severe uncontrollable pain? Have you got an electric shock feeling shooting down your neck, down into your spine when you look down? Have you lost feeling, or have you got weakness in one of your arms or legs? Have you got back pain and you've lost control of your bladder or bowel? Have you got numbness round your bottom in your buttocks or your inner thighs? Or have you got difficulty in walking combined with neck pain, and the problems walking came on when you got the neck pain? Have you had cancer in the past? Have you got pain in your mid-back behind your rib cage? Yes or no? Patient answers no. So it's okay, is it, if I click none of the above? Yes. So the patient then clicks none of the above, but we are going to stop them and say, you've got numbness around your bottom in the buttocks of the inner thighs, and the patient's going to say, yes, I've got that. So when you click on that, this is really important. Not only does this form allow you to see whether the patient is suitable, and only if they click none of the above is the patient suitable, but if the patient clicks one of the others, if the patient answers yes to one of the other system, it doesn't just tell you that they're not suitable, it tells you exactly what you need to do. So the reception advice is needs to see a clinician this session. This patient needs to be seen by a GP or clinician today during the current surgery session. So that gives you advice not only on whether the patient needs to be seen, but how urgently. And there are 3 different options there. One is GP immediately. And GP immediately would be, for instance, the patient's got a rash, and when you ask them, they say that they've got a rash which doesn't fade when they press a glass against it, and they've got they don't like the light, and they've got neck stiffness. So in other words, they might have meningitis or meningococcal septicemia, and at that point it would say GP immediately, and the advice to the receptionist is please interrupt the duty doctor, whatever they're doing, ask them to see the patient immediately, and if they are not available, please ring 999. Then there's GP Now, which is the patient can wait, but they need to be seen this session. So please make them an appointment during the current surgery session. And then there is the option of GP Later. And that might be, for instance, an example where a patient has acne and they've tried 2 or 3 over-the-counter medications from the pharmacy and none of them have worked, or the patient's got acne and signs of polycystic ovary syndrome. So they don't need an urgent appointment, but they do need to be seen by the GP. So that, as I say, gives you not only advice on whether the patient needs to be seen, but how urgently. Now, what you can see at the bottom is what we're in the process of developing. We have completely developed this and it's all set to go. We're just waiting for sign off from NHS E&I, and this will be a patient self triage version. This is completely different to self-referral. The patient will go through exactly the same process that you've done, and most of our receptionists say it takes between 2.5 to 3 minutes to go through that form, as I've mentioned, but that will mean that you won't even have to do that. If the patient rings up, you can say, have you got any of these symptoms? Well, just go onto our practice website and you can use our form, and if you do, then you can get an appointment within a day or today to see the pharmacist, who will be able to give you exactly the same treatment that your doctor would be able to prescribe on prescription, or indeed maybe able to give you things that your GP is not allowed to prescribe. So if we then just go back, and again, those questions are going. We're going to go back to back pain, and the patient hasn't got any of those symptoms. They've clicked none of the above. Now, let's do lower back pain address. At this point, this will come up. Now, you will not obviously always have time to read this through with the patient, but for instance, some of the practices we've got are taking a copy of taking a computer, having it at reception, and turning the computer around so the patient can complete it themselves, or they have a computer somewhere private or an iPad somewhere private themselves where the patient can go and complete the form. And at this stage, we give them lots and lots of self-help advice. This is something that our GPs are really, really keen on. Our first pilot was with Northwest London, actually with Camden, and they were very, very keen that we should provide some self-help information. So for instance, any of those pink ones, this is a test system, so it doesn't actually work if you click on them, but within the system itself, if you clicked on, you can find out more when you need to seek medical help from our video. It brings up a 1.5 to 2 minute video. All of these come from patient.info, which I'm quite sure you use on a daily basis. Of course, it's what you will know as the mentor replacement, or otherwise patient.co.uk, as many of you still know it. All those videos, like all our patient information leaflets, are provided by a GP, the information in them, and peer reviewed. So those are 1 to 2 minute videos, and they have closed caption subtitles so that you can actually use Google Auto Translate and translate them into local languages. But if you go a little bit further down there, you can see there are several links to leaflets. You can read our leaflet on neck pain or lower back pain. You can read our leaflet on sciatica, and then the video with the accompanying leaflet from our physiotherapist. The patient can click on that, and that brings up a video with the patient, with the physiotherapist rather, demonstrating back pain exercises, and we have leaflets that go with it, so the patient can then download the leaflets and continue to do the exercises themselves. Now, on this occasion, what we've said is, this is some self-help information. You may well not need to see a physiotherapist, see a pharmacist, but if you do, please click on Create Referral if you'd like to make an appointment. On some of our other forms, we say your answers suggest that there is nothing serious, there is nothing urgent that requires you to see a GP. However, a pharmacist can help with your symptoms. Please click on Referral and then give some information. So some of them we're saying to the patient, you may not even need to see a pharmacist. You could self-care, but some of them, and again, this is determined by at least 2 GPs working in tandem, reaching a consensus, will say you need to see a pharmacist rather than a GP. At any stage, the patient can decline the referral. Now, what we've interestingly seen is that since we have introduced this, because we've already said, is it okay if we proceed, the receptionists have said, well, nobody declines. Why have you bothered to have that button? Because by this stage, we've gone through it all with the patient. We've explained to them they're going to see a pharmacist. And we've got, but the point is that we want to have that option to give the patient choice. But nobody, as far as we're aware, or virtually nobody, has declined at this stage. So at this point, we're going to assume that this patient is one of the many and does want to have a referral, and we're going to click on referral, and this is where we go through to the elements. We've had several questions coming in about, for instance, the pharmacy end of it, what happens at the pharmacy end. So let's click on create referral, and you can see what happens when the patient has when the receptionist creates a referral.
So thanks, Sarah. Before I click that button, I just want to say the new version of this solution that's coming out. So you saw in here that the leaflet's available on screen. In the new version that's coming out, you'll be able to actually click on the document and then able to print that document as well. So you could then hand to the patient a printed document from that perspective. And in the future, there'll be a digital referral that will be available as well. So I just want to make that note, just in some
really good point. And in the new iteration, along with it being filed back to the patient record, the patient will also, as I mentioned, receive confirmation of their appointment, and in that confirmation they will receive these details of the information they've received, the self-care, and all the live hyperlinks.
Cool. I'll click on create referral. So should I take over now, Sarah?
Absolutely.
Okay, so by clicking on create referral, so you've gone through the clinical triage example that was just demonstrated. I've got my video off because I seem to be having bandwidth issues and I don't want the demonstration to fail. So what you have in here is the metadata that's been pulled from the GP record itself. If you remember, I described to you earlier what data is pulled through from the GP record. So we get the demographics information in terms of first name, last name, phone number, home phone number, if there is one, an email address, a bank dot or the postcode in this example. Also the first line address, gender, NHS number, date of birth, and obviously you can put in here some notes for now. So you can say in here, I think we went a little with lower back pain. But I mean, I'm not a clinician.
Yes, that's absolutely right. But don't forget that in the new version, again, because the details with a summary are going to be pulled through, you're not going to have to do that. All the details will be entered into the patient record. A copy will be sent to the patient, which is a patient version, patient information leaflet version, and the details will all be sent to the pharmacist, so you won't need to enter anything in there. Okay,
thank you. Obviously, you can put a note in here, and anything you put in here then also will be sent through to the pharmacist as well. So if you can remember the postcode M88PY, and if I click on continue, what happens is a list of pharmacies that have signed up for the GPCPS service within a certain mile radius get presented back and listed in the left-hand side, as you can see in here. I'm flicking between the two different ones. What we do is we take the postcode of the patient in terms of what their registered address is. But if you can imagine a hypothetical scenario that one of your patients is going to be, I don't know, I'm going to say they're a Manchester patient who are going to be in East London, so I'll put E7 as an outer code search area. Then we can see in here when you do the search, it will then list back pharmacies that have signed up for that CPCS service in that postcode area as well. Now, the key thing to bear in mind is this is a national service. So in theory, you can refer your patient anywhere in England for a CPCS referral. If they and we have in our system enabled around 11,500 pharmacies who are signed up for this GPCPS service are available for referral in the system itself. So if I now go back to the postcode that the patient's at, which is M8, and search, what you see in here is we pull the data from the DOS itself. So we get back the address, the name, the contact details that is registered in NHS Choices. We also get back the opening and closing times, and we also then create a map based on where the address is based on the postcode area for that pharmacy. Now, it is, I don't know if there's any pharmacy colleagues on this call or not, but it is vitally important that the data that is stored on the NHS Choices is accurate in terms of opening and closing times, because this is what is used by practices to then refer the patients into to your pharmacy. So if you can take the hypothetical scenario as an example, this pharmacy is shut on a Saturday and Sunday, and the pharmacist and the patient contacts the pharmacy at say 4 o'clock on a Friday evening, then this pharmacy would not be suitable for a referral. So what would happen in this case is they'll choose a different pharmacy, so in this case Everton Pharmacy, and then you can then refer that patient on to this pharmacy because it's the next nearest one that's available or local to that patient who's open and can be seen within a 24-hour period. I don't know what the Northeast London policy is. I don't know if Zara or Sarah have an idea on this one, but
Bazana, I don't know if you know, but if, for instance, in some areas, officially this is a same-day service, but of course, if you've got somebody who's been referred at 5:30 at night on a Friday, and if the pharmacy is closed on Saturday, you cannot expect them to be standing by their machine waiting for a referral. So many CCGs are saying if a form is sent it'll be within 12 working hours. So if it's sent before 4 o'clock in the afternoon, they're saying that you are required to respond the same day. Sarah, you've got a response for us.
Thank you, Sarah.
I do. So the response is officially from the LPC. If the referral is made before 3 p.m, it will be dealt with on the day. Anything after 3 p.m, please advise the patient that by tomorrow lunchtime. Of course, they might deal with it on the day, but to be on the safe side. So anything before 3 p.m. is on the day. Anything after 3 p.m, say the pharmacist will contact you by tomorrow lunch.
Great.
That's really helpful. Thank you very
Zara.
much. It does vary
So
between CCTs.
If I carry on with the demonstration itself, then obviously you've got in here a send referral and patient declared. I know there are some questions which have been put out there, but I'll come back to them in a second. So you click in here, you've chosen the pharmacy that you want to refer this patient into, and click on send referral. So what happens now is a number of technical things which are happening in the background. So an email is sent to the patient with the details that you saw about the pharmacy in terms of the opening and closing times, the address, and the service that they've been referred into. An optional SMS can also be sent to the patient. I'm not sure if NEL have signed up for an SMS message, but that is a capability that is available. And a digital, clinically safe, data secure message is also sent into the pharmacy system using an ITK message format. And we use the API that's available in Pharma Outcomes to pass that data across. We know that there's a possibility to send this via email, but we just believe sending it via secure ITK message gives us a better control, but also more importantly, it provides an audit log to make sure that the referral is entered into the pharmacy system, and the pharmacy has also picked that referral up as well. So it provides a full end-to-end flow from that perspective. If I now click on patient access again, I just want to describe the other two buttons that are available, the create referral and the referral report, before I hand over to Kevin, who will describe what happens when the referral lands in the pharmacy system. So create referral, as Sarah mentioned, is you may already get some input back from a patient through some consultation process, whether it be online consultation, e-consult, or AccuRx consult, or any other consultation mechanism that may already be available. And in that situation, based on information that's been provided, you can see that this patient does not need to be triaged. I can make a judgment call that this patient can be referred into a pharmacy for a CPCS referral, or the care navigator who's taking the call of the patient could be somebody who's suitably qualified from a medical perspective, who does not need to use the triage capability, and just by asking the right questions can then just refer the patient on, and you've got that opportunity to do that, to bypass that triage flow that I just mentioned. And the other one that I wanted to add was the referral report. What this provides is an audit report of all the referrals that you've done. What you can also do is export that report and for processing offline, and it will give you a summary report of all the referrals that have taken place, who referred the patient, which patient was referred, the date of birth of that patient, where they were referred to, the postcode. We also include the NHS number and some additional data that can't be seen on such a small screen here as well. So that kind of, from my perspective, concludes the presentation of how it works from an EMIS web perspective. I'm now going to hand over to Kevin, who will describe what happens when the referral lands at pharma outcome site or pharmacy site, and then we'll come back to some questions that are available here. Okay.
Thanks,
so
Idris.
Kevin, I'm over to you.
Yeah, thank you. Thanks, Idris. Thanks, Sarah. I'll just grab the screen and hopefully you can now see a pharma outcomes homepage. Has that popped up?
Yep.
Brilliant, thank you. So Idris mentioned when he clicked send referral, a couple of things happen, and the ITK message will come directly across into the services page of pharma outcomes at the pharmacy. The pharmacy will be alerted of that referral receipt. There's a number of ways the pharmacy is alerted. The first is a message that gets sent by email to the pharmacy management email account. So every pharmacy can set a management email preference from their homepage, and they can set more than one email address in this field separated by a comma. So typically we see each of the pharmacists setting a preference. This doesn't have to be a secure email address. It's probably better for it not to be a secure email address, because now and again we have fun and games with nhs.net servers blocking emails because of the volume that gets sent out for this service. I guess there's some spam filtering and stuff like that. So always good to set both types of email address there for management email if you can. There's never any patient identifiable data that's sent in that alert. It's just a message to say this surgery has sent you a referral for GPCPCS. Please log in to action that referral. The second alert type is something called Pharm Alarm. So I know more and more pharmacies are acquiring a Pharm Alarm. This is just a little USB device that pops into the USB port in the pharmacy computer. Comes with an extension cable, so typically we see it attached to the side of the pharmacy monitor screen. And this flashes when a referral of any type arrives into the Pharm Outcomes Services page. So that would flash for GP-CPCS referrals in a discharge medicine service, referral arriving in the services page, and also an NHS 111 referral arriving in the services page. So those are the two mechanisms to alert the pharmacy of receipt of a referral. The referral itself goes straight into the workflow at the pharmacy. So this is the services page, and the referrals arrive and are quite conspicuous in this page because they appear at the top of this page. Usually this page starts here with a record of historical service provisions, clinical records, but referrals that arrive into the pharmacy will arrive at the top of the screen. There's quite a lot here because we're demoing this quite frequently, but there's generally one or two only that will be appearing at the top of the page, so that they do stick out like a sore thumb. So this is the referral that Idris has just sent to me, and to open up the information, all I do is click on it. And this will give me information on which GP practice has sent the referral, the patient demographics, the patient contact details, and the reason for referral, which was low back pain, and the patient has tried some paracetamol. So there are three options here. The patient can, or the pharmacist can either close the referral. So they would only be closing the referral if the patient hadn't attended. So bearing in mind what we've just heard from Zara, this would be if the pharmacist had made contact with the patient after non-attendance and the patient had confirmed they're not coming in. They can only close the referral if they put a reason in the box above. So the audit that's available to you in Pharm Outcomes, because we also provide each surgery with access to Pharm Outcomes to see a detailed end-to-end audit that shows you all of the information the surgery has sent and what's happened at follow-up and the status of all the referrals. The reasons for closure will appear in that audit. Accept just changes the status to I've accepted the referral, but it remains at the top of the screen. And when the patient attends the pharmacy, they click on complete now. If this patient was a real patient, and this instance is not, because all of this is just non-PID, this is just examples to show you how the system works. But in reality, if this was a real patient, the first thing that would appear here would be a PDS match for that patient, and the pharmacist has the ability, or they need to confirm that that is the correct patient to continue with the consultation. When that's confirmed, what happens is this little hang tab here becomes live. It turns from grey to orange and is clickable, and that's a quick read through to the patient's summary care record, provided the pharmacist has a valid smart card in a smart card reader with the right role-based access code on it to access the summary care record. So they can quickly look at the summary care record to see if there are any reasons or anything in the history for this patient that they need to take into consideration. Consultation type, either telephone or face-to-face. If we sort of slowly now returning more to face-to-face contact in pharmacies. And then there's a question to ask if the patient's accompanied, and if they are accompanied, who's accompanying them, and do you have consent for that person to be present during the consultation? If the patient isn't accompanied, then those questions remain hidden. There's a quick clinical check to ask questions around existing medical conditions, allergies and sensitivities, if they're currently taking any medication. And if any of these are ticked, a little warning comes up to say, please take care when considering or selecting any treatment, and bear in mind that the patient is taking a particular type of medicine. It doesn't prevent support, but just highlights the need for extra care when selecting appropriate medications. If none of the above apply, then obviously that warning remains hidden. There's then a drop down to select the reason for the referral, and in our case here it's lower back pain. A little pop-up to say beware of any red flags. The great thing about the clinical triage that Sarah's gone through is it's an excellent filter for ensuring that inappropriate patients don't find their way through to the community pharmacy, but there'll always be a second check anyway when the patient arrives at the pharmacy, and there's a link here to take the pharmacist through to the nice clinical knowledge summaries that they can access all sorts of information here that will support the patient and help them with their consultation. So the service specification requires confirmation that clinical knowledge summaries have been checked, and there's a confirmation here that no red flags apply. Answering that no allows the consultation to continue. Answering that yes will reveal the process to follow, whether the consultation is taking place in hours or out of hours. We're going to assume that there are no red flags here. So we've got here that the back pain has lasted for 24 hours. So we're in 24 to 72 hours. The ability to record anything taken to date. And we know from our referral that paracetamol has not helped. So I can record that. And are there any other associated symptoms? And again, the ability to document that if the answer to that question is yes. We've now got the outcome of the consultation. So 9 times out of 10, it's going to be appropriate advice or appropriate advice for the sale of a medicine. I've seen a question come up in the chat about a locally commissioned minor ailment service. If there is a locally commissioned minor ailment service, then this allows supply of medicines through those services. So you can select that as an option. If the patient is being referred through to the pharmacy team, maybe for something like uncomplicated urinary tract infection, and there's a local PGD that can be used for supporting those patients with a short course of nitrofurantoin, then it could be that the outcome is appropriate support using a locally commissioned patient group direction. If the patient is signposted on or escalated, or there's a reason that the consultation has concluded and none of these reflect the outcome, then there are always more fields to capture information around escalations or further signposting, how the patient was signposted. And all of this information is documented in the GP notification that gets sent when this record is saved. So you'll always know what the outcome is.
I'm just going to jump in there and point out that we had a meeting with NHS E&I when we did one of our, excuse me, wider area meetings about 2 weeks ago, and we were advised that currently the number of patients who have to be escalated or sent back to the practice, and usually sent back to the practice, is in the region of 9 to 11%, so about 1 in 10 of those patients. Now, we have thus far, we're now, as I say, live in over 2,000 practices and have been going for nearly 2 years. And I say this every time we do a meeting, and nobody has taken me up on it yet. If you ever have a patient who gets to the pharmacy and who is turned away on the grounds that they have gone through the triage, and despite going through the triage, they are unsuitable to be seen and they need to be escalated, please let me know. We've had one feedback where in fact it transpired that the patient's condition had changed, and despite being advised that if your condition changes you should get back to the practice, they continued to attend the pharmacy, but they had developed one of the symptoms that we had checked, we'd asked them to check. Other than that, as far as I'm aware, we have no patients who have required escalation as long as their condition has not changed since they went through the triage. So effectively what you're going to be able to do is not only to avoid patients needing to attend GP consultations, but also really importantly, by using the triage tool, you are effectively going to be able to eradicate the risk of that 10% of patients coming back very cross because they wanted to see a GP in the first place. They were fobbed off with, which can be their view, a pharmacist, and the pharmacist is now told them, having gone to the trouble of making an appointment and going in, that they need to go back and see the GP. That is not a happy experience for patients, and it's not a happy experience for the reception team who has to cope with them when they go back to the GP practice. Effectively, as I say, we, as far as I'm aware, we have pretty much, and in fact, we have managed to eradicate that by using the triage service.
Great, thanks, Sarah. Really, really helpful, really useful information. Thanks very much. So we're going to assume here now that this is proceeding with appropriate advice on the sale of a medicine. The next part of the consultation is recording that medicine supply. So the service spec requires a record of the medicine supply. So it might be, in this case, the advice is to try an anti-inflammatory if paracetamol has been ineffective, provided the patient can take an anti-inflammatory and all the other advice is given on taking it after food, etc. It may be that we're going to give some ibuprofen 400 milligram. And a record of the dose also goes into the record. If a second medicine is being supplied, then you can record that in a second set of fields, but if it's not, then those fields remain hidden. And then the consultation is closed with an aid memoir list just to remind the pharmacist the things they need to cover under the service specification. It's things that you would generally cover anyway in a patient consultation, how to manage their condition, how to take the medicine to make sure that they're taking that correctly and it's appropriate for them, and the action to take if their symptoms get worse. If there's any signposting to electronic information resources or printed leaflet resources, these boxes can be ticked. And advice on managing future minor illnesses appropriately. There's a notes field where you can add in additional instructions or information you passed on to the patient and a record of who you've advised, the patient or the patient's advocate. And then all consultations need to be closed with, if your symptoms don't improve or they get worse, you should go and see your GP or come back to the pharmacy. You can call 111 or 999 if the matter is urgent and a pharmacist or GP is not available. So they're required to tick that advice has been given. And that's the end of the consultation, really. There's the ability here to report on incidents or send messages to the service commissioner that's monitored if that applies. And this is the field that you would record supplies under a patient group direction, such as the nitrofuran towing example that I mentioned earlier. There's the ability for feedback here that we monitor, ways in which we can improve our service or help people navigate the follow-up more effectively. And then saving the record will do a number of things. The first thing and the most important thing I would imagine for the people on this call is the GP notification is automatically sent. So the GP notification currently looks like this. It's aligned with the requirements set out in the relevant appendix of the service specification. and will give you information on the patient, the reason for the referral, the presenting condition at the pharmacy, the outcome of the pharmacy, so appropriate advice and solar medicine, and details of the medicines that were supplied. The name of the pharmacist appears on the bottom and the name of the pharmacy appears on the top. So if you have any queries that you need to address, those contact details are provided in the notification that comes back to the GP. So at the moment, the route back to GP is via NHS mail. So we would ask that practices ensure they have a valid nhs.net mail set for the purposes of receiving notifications. This year, at some point in time, the mechanism of feedback to GP practice will change to MESH. I understand now the fire specification has been published by NHS Digital for this message. So we're now in the stage where the system suppliers are looking at creating that message. So we need to create what's called a fire message, FHIR, that sends to the GP system into the MESH mailbox. So I anticipate that happening at some point in time this year. But the system suppliers need to develop the ability to send and receive that at this stage. So that's what happens at the community pharmacy. I don't know whether anybody has any questions on that or anything's popped into the chat. I'm sure Sarah's been looking at that.
I have indeed, and we do have lots and lots of questions. So I would suggest, if I may, in the interest of time, Kevin, just because we only have 10 minutes to go, Fazana, is it okay with you if we just zip through the questions in the chat and see what we can answer in the time available? I can stay on for a little while longer if needed, but regardless whether the patient has a patient access account, as we've mentioned, this is nothing to do with patient access. They do not need a patient access account. In relation to System 1 practices, there is a web version to log into for System 1s. You do not need to have login details for it. Once it's been activated in your practice, you will automatically, if you're able to log on to System 1, be able to open it up. When patient access referral go live, Fazana, I think that's one for the CCG, so I'm not sure. I don't know if anyone from the CCG can answer that.
Sarah, do you want to answer that one at all?
It should be live for everyone from what I understand, but if there's any problems with when you're clicking it, it's not coming up, just if you put it in the chat, we'll pick it up because it should be live for everyone.
Great.
Certainly
Thank
live,
you very much indeed.
certainly live in Newham, but yeah, just pick that up.
Thank you, Fazana. If we send the patient for pharmacy for BP checks, the patient pay the pharmacy for the service, not if they are sent under the hypertension case finding service, but they have to be over 40 and not under the care of a GP or a practice for hypertension or for blood pressure monitoring, or the GP needs to be referring them specifically for ABPM. So it's a slightly different service. That's a national service and is separate to this one, but it may well be that it will become available as one of the options on local services, which of course is what Patient Access Connect is going to be changed to. If we send the patient, oh no, that's the blood pressure. Let's have a little look. How does it appear in the pharmacy system? I think you've seen. Any tips I can differentiate to patients, a community pharmacist and a practice-based pharmacist ACP? Kevin, I think you've covered that really, haven't you?
A practice-based pharmacist ACP. Can somebody tell me what the acronym stands for, please?
Oh, I thought you'd know. Because I don't.
The advanced clinical practitioner, is that
Independent prescriber?
Do you want to come on? Who put that question? Was the question?
That was me.
Simon.
Can you hear me?
Hi. Yeah, hi.
Yeah. So I guess my worry is I'm a pharmacist, and because I'm an ACP, I see a bit more undifferentiated cases. I guess my worry is that the patient gets sent back to the surgery, and then the surgery say, fine, we'll book you with our pharmacist, and the patient might find that confusing. I don't know if I'm overthinking it a bit, but I'm just wondering,
well, the good news, Simon, is that, as I say, if you use the clinical triage, we haven't had any patients being sent back to the pharmacist, to the practice yet, so hopefully that will cover it. Is this working better in areas where there's a funded minor illness scheme so patients in deprived areas don't need to pay? It's a really good question, and this was an NHS decision nationally that pharmacists would be paid for providing the service. They would not be paid for providing patients with medication, and that medication would need to be bought. Now, this is very, very much part of the NHS's push to get people to buy medications which are routinely available over the counter. And indeed, in patient.info, we've recently started adding points where the under the NHS England scheme for medications which should not routinely be prescribed in primary care, we have started adding details and making the point that the NHS has advised doctors that they should not routinely be prescribing these. I completely understand. I work in Shepherd's Bush. It's a deprived area there, and I do understand that some patients don't want to pay 32 pence for 16 paracetamol. Unfortunately, in many cases, in a significant proportion, I think it's about 30% of cases, when the patient goes to see the pharmacist, then they are simply provided with advice and they're not recommended to buy anything. They're just not even over-the-counter medication. It isn't a service which, as I said, this was a national decision which includes providing medication for free. There are local minor illness services. There is no national minor ailment service. That question seems to have come up several times in the whatnot. There are some, and different CCGs will make different arrangements. So, for instance, in a CCG that we did a presentation to 2 weeks ago, they have made the decision that they are going to provide a minor illness service, but it is not going to be for everybody who gets free prescriptions. It is only going to be for a much smaller group of patients, and I think it's patients who are registered with learning disability, mothers of children under the age of 5, people over the age of 65, and so on. So it's not, it's not an automatic. If you're eligible for free prescriptions, then you're eligible to get this anyway because you're on income support. So local CCGs can determine whether they have this, and if they have determined whether they will use it, at what level they will use it. Now, Kevin has already pointed out that you can provide something if you have a locally commissioned minor illness scheme. But yeah, I do appreciate there have been a couple of questions coming in about what happens if the patient then comes back. And I think the answer is that we have had to have some fairly robust discussions within our practice about what we are going to do about national NHS policy. The simple fact of the matter is that NHS policy is that we should not be prescribing paracetamol for minor self-limiting conditions. We should not be prescribing knit lotion. And you need, I think, to get consistency within your practice. I appreciate that can be difficult, particularly if you have locums working in the practice. But if you can get consistency within the practice, that seems to be more of a determinant as to whether or not it goes down well with patients than how deprived the area is. If we then go on, will the patient document and questions be available in other language? No, I'm afraid not, because there are all sorts of clinical governance issues in terms of translation. However, I'm sure many of you, Fazana, I know that you use online consult, and that actually the receptionists have not found it that difficult, because there's always pretty much always a family member who can translate. Do you want to speak to that at all?
Yes, and in fact, interestingly, Sarah, we've been using a lot of online consult, and patients, the majority have English as a second language for my patients, but they prefer it to the telephone, although we have language line commissioned here, because they'll have lots of translation facilities. So that's been really interesting. That just hasn't been the problem that we thought it would be, but many have preferred it over telephone with translation services.
Thank you. That's really helpful. Somebody's requested a copy of the video clip, which will be sent. The recording will be sent in. It will always. Oh, how does the patient get the self-help advice information, links to videos over the phone? So the answer is, if a referral is made to the minor illness service, then in the new system, which, as I say, is coming, we hope, within the next month, then an email will be sent to the patient. And you need to check the patient's email address is current, obviously. But when that comes in, then what will happen is the patient will receive a copy of the referral letter telling them what to do, but it will also include details of that summary form, which will include hyperlinks to all the patient information leaflets. Is this session available for future sessions? Well, I'm perfectly happy for it to be used, and it is being recorded, so I think so. Can we have a certificate for appraisal, Sarah?
Sarah, might there be a certificate?
If you really want to, you can do. It's not, I mean, it's more of an information session. I'm not sure if I'm providing you with CPD right now, but I'm happy to give you a attendance certificate.
Somebody who's been a GP appraiser for many years, again, you can certainly note this in your appraisal. Even without the certificate, you can just put the things you've learned. I've certainly learned lots this afternoon, so feel free to put this in your appraisal if you've learned anything. That's absolutely fine. I've learned loads. Just in the interest of time, I know we've got 1 minute. Sarah's doing a great job. Sarah, can I just ask you to pick the, did you want to just pick one
Yep.
more?
So do we hear back from the pharmacy in terms of outcomes? You've heard from Kevin that yes, you absolutely will. Can a referral be redirected to another pharmacy if needed? Not as far as I'm aware, using the same referral. Kevin or Idris, perhaps you can confirm that. But of course, we do get the patient to confirm that it's appropriate for them. And one would hope that they're not going to have changed their mind within the next 12 hours.
Yeah, so I mean, it is possible. I mean, there's not a built-in mechanism to do that as there is with urgent medicine supply, because it's not in the service specification as far as the IT suppliers are concerned. But the pharmacy that the patient presents at could be referred to another pharmacy by that pharmacy, for example, if they didn't have the medicine that was required in stock. And there's a standalone template that can be completed at pharmacy B to record the intervention that will again generate a post-event message back to the GP practice.
Thank you very much. If there's no specific time to attend, in what way is this different from reception, just advising the patient go to the pharmacy? Well, if you go to the pharmacy, the pharmacist might not be available. They may be busy. Secondly, you're getting a lot of information, patient self-help information, which is going to go to the patient. And thirdly, perhaps most relevant for practices, as of the 1st of April, there will be money attached to making referrals to the GPCPS. So actually, if the receptionist just tells the patient to go to the pharmacy, then that will not be a referral. That will count as self-referral if the patient turns up without a referral. The pharmacist will not be able to claim for it, and neither will the practice. When sending a referral, how do we know which email the pharmacy wants to use, Kevin? It doesn't. You don't need to use an email. You don't need to send an email to the pharmacy. It goes through automatically through Patient Access Connect. Unless I'm missing something, Kevin.
Absolutely right. Yeah.
Yep,
No need
lovely. Yep, lovely. And let's have a look. I think we're nearly getting there. It's not appearing on Patient Access just yet. Let me see. Nearly there. There is no national. No, I've made the point. There is no national service.
And no, they don't have to be referred to their nominated pharmacy. They can tell you which pharmacy it is, don't they, Sarah?
Absolutely. So we have got a couple more comments about patients who are eligible for free prescriptions, but I hope I've covered all of those. If someone could put their hand up if they haven't. And I think that is it. What gets back to us from the pharmacy in terms of outcomes, will this ever include requests for action from the GP? Well, the answer again, I go back to this comment. In 10% of cases, if it's referred using the standard NHS CPCS form, GPCPS form, in about 10% of cases, there will be escalation back to the GP. Thus far, we haven't had any cases where the patient has needed, the pharmacist has needed to send the patient back for further action from the GP, because if the pharmacist is dealing with it under the minor illness scheme, then by definition, they are providing the treatment. Is the demand previously met by community pharmacists going to be redirected to GPs? No, I don't think so is the answer. And certainly if we can get minor illness, CPCS rather, through patient self-assessment, then I would very much hope that it is going to reduce your workload. The other point to make is that none of the conditions for which we're referring are quaffable, and therefore the practice won't be losing income. When we raise a referral, does the read code enter into the patient's notes automatically? Idris, I'm going to leave that one to you. But what we are going to have under the new system is it'll say that there will be a SNOMED code for referral to GPCPS, which will allow it to be audited automatically for claiming. Is there anything I've missed there, Idris?
No, you've answered. I'll just put a comment on that. It's not in the current version, but it's in the release that's coming up in April post the QoF code freeze.
Sorry, I think I confused the issue. I responded about the pharmacy notification back to GP after the consultation. Sorry, I misread.
Again, we've got another question about paying. Pharmacists have pushed back on this and said patients usually want medication without paying for it. Again, that's down to, there is nothing we can do. This is a national service, and I think it's down to practice, education of patients and practices having a policy. Given that 98.8%, I think, of pharmacies in the country have signed up for it, I think they'd be pushing their luck if they started pushing back now, because they're taking the money for it. We have the button, but it doesn't follow the triage process. It goes straight to the screen to refer a patient and pick the pharmacy. Is this right, Idris? I suspect they may just not be clicking the button which says refer for assessment.
I think they're pressing the top button, not the middle button. So I
Yep.
put a comment in the notes.
Yep, thank you. So the middle one is refer for assessment rather than, assess for referral rather than create referral. Okay, answer the question. Yeah, so pharmacies do get paid for providing the CPCS consultation, irrespective of whether the patient is referred. Yeah. I think we are pretty much done.
Thank you very much, Sarah. And if anybody feels they didn't have their questions, do feel free to, Sarah, would it be all right, Amita? So do feel free to email if you have got a question that's burning. And I'm pretty sure, Sarah, so is that all right, Sarah?
Yep.
That's brilliant. So thank you everybody for staying on, and particularly to us. A massive thank you to all our speakers for a really, really interesting hour. And it is all live. Certainly from my own experience, been using it for 6 months now, it has definitely, we get about a GP session of workload per week, about 16 of our patients going. We certainly don't even get 1 in 10 back, particularly in North East London, where we know a lot of our population do have quite a high health seeking behaviour. And our community, we certainly at our practice at Project Surgery couldn't live without the community pharmacy consultation service now, getting a free session every single week. So I hope this has been useful for you. A very big thank you to all our speakers again, and to all of you. We hopefully will be sending out this recording to you hopefully by tomorrow. So have a lovely afternoon, everybody. Thank you.
And thank you for hosting me, and big thank you to Fazana for chairing.
Thank you.
Bye, everybody. Bye-bye.
Right.